awareness about fatty liver disease to healthcare professionals, patients, and their families. Today, we are honored to have Dr. Vivan Talwar, a renowned gastroenterologist from Delhi, as our guest speaker. Sir is known to provide exceptional care to his patients for treating various gastrointestinal disorders. His commitment to patient-centered care and spreading awareness about MASLD is truly commendable, and we are grateful for his dedication to improving liver health and educating others about this important topic. So, without further delay, I would like to invite Dr. Talwar to share his valuable insights on management of MASLD. Over to you, sir.
Thank you, Katie, and thank you to the company as well, to all of you for inviting me. I've done this a few times before, so I'll stick to the same template. I like to keep the presentation short and simple so that the questions can be more, and I find they're more informative. So I'm speaking today a bit about what is commonly called fatty liver, which is of epidemic proportions in not just India, but in the world. Historically, it was always called NASH and has been relabeled as MASH to some extent. And I'll go into details a bit about this, trying to keep it simple throughout as well. Okay, so the liver is one of the largest organs in the body, and it has multiple functions. It's present in the abdomen or in the tummy area and the upper right area. And it's got multiple functions, which I have presented in the slide out here below. The single most important function that I'm going to focus on right now is in the bottom center, which says controls 500 metabolic processes. So what are metabolic processes? Metabolic processes are basically processes going on at the cell level in our body that controls how our body regulates itself in terms of how we digest food, how we breathe, how we use nutrients, how we transfer nutrients from one place to the next. So the liver is focusing basically on this. So this metabolic process, when it is abnormal to some extent, causes fat in the liver. And that is why the disease of fatty liver is called MASH or MASLD, which essentially stands for metabolic dysfunction associated steatohepatitis. So basically, in simple words, due to abnormal metabolism, the liver gets fat in it, and the fat itself can cause damage or inflammation in the liver. So again, I'll talk about this a bit later in the next couple of slides. So it used to be called NASH or NAFLD, and the term NASH, which stood for non-alcoholic fatty steatohepatitis, or NAFLD, which stood for non-alcoholic fatty liver disease, are basically fancy words which were used before when we found fat in the liver or fat with inflammation in the liver, which was not due to alcohol. So we don't talk about alcohol today. This is in people who are non-drinkers or mild drinkers, moderate drinkers who have got fat in the liver and potentially even damage going on in the liver. And this disease called NAFLD, NAFLD, is now changed to MASLD, with the M stands for metabolic dysfunction. So again, going back to what I said earlier, the abnormal metabolism in the liver causing dysfunction in the liver, or NASH, now called MASH, MASH. Again, pretty much the same thing from all practical purposes. What is it? It is basically fat in the liver when at least 5% of the weight of the liver has got fat. Once again, I repeat, it's not in patients who with alcohol. Alcohol patients who drink excess also get fatty liver, but we call that a different disease, and we're not talking about this today. So who do we see fatty liver in or MASH or MAFLD or whatever you want to call it? We see it in people who are obese. We see it in people who are diabetics. We see it in people who have high lipids or cholesterols or fats in the blood. And we see it in some people who don't have any of these. So this is what we are going to be talking about today. Why are we talking about it? It's because of this slide. This shows you how common it is. Up to 1/3 of patients across the world are reported to have fatty liver. And this is a rising problem as the world gets more prosperous in terms of diet, and in urban cities where lifestyle is all about a fast pace of life, ordering food from outside, taking processed food, weights are increasing, and as a result of that, you are having patients who are getting obese, patients are getting diabetic, and we're getting fatty liver. So as you can see from this slide, in India, In Asia, it's up to about a third, and going up to, if you look at the Middle East, it's also a third. In South America, it's up to 40%. So it's as I said to you, it's of epidemic proportions, and it's one of the diseases that is going to explode simply because in the diseases of metabolic diseases, in that whole package of metabolic diseases, not just does fatty liver come, but the associated diseases, the obesity, the diabetes, the high cholesterol, the lifestyle, all comes as a package in it. And that's why we're talking about it. And that's why we're trying to spread awareness out here. People are very often told in ultrasounds that they have a fatty liver, and they don't understand the implications, because fatty liver per se on its own at that particular time does not necessarily cause symptoms. So most people don't even know they have fatty liver, and they don't even have symptoms from fatty liver. The problem is in these people is that over the next decade or couple of decades, this fatty liver progresses, and it progresses to scarring of the liver, what we call fibrosis, and eventually we get death of a part of the liver, and we call this cirrhosis. So as you can see from this slide, you're going from a normal healthy person who starts getting fat in the liver, what we are calling nowadays MASLD. When this fat starts causing inflammation or damage in the liver, we call this MASH, MASH. When this scarring starts becoming early irreversible, theoretically, we start calling this fibrosis. And when this becomes totally irreversible, we call this cirrhosis. And this is what we call in simple words, liver failure. In fact, in India, one of the most common causes of liver transplant is actually from fatty liver. So just a few technical things. What's the main difference between the two of them? If you look at the left-hand side of the screen, MASLD, MASLD is simply having fat in the liver. At this particular point, the liver is not showing any active damage in the liver. It's showing just simple fat that we are able to see through various tests, which we'll talk about later. When this fat starts causing inflammation, and when I say inflammation, I mean simple swelling of the cells, as simple as someone hitting you on the arm. When your arm swells up, that's inflammation in the arm. So when this fat in the liver starts causing inflammation in the liver, we call this as MASH. And this is the first damage that will lead to further scarring, eventually causing fibrosis, and later on into what's called cirrhosis or death of the liver. So what are the causes of fatty liver? Well, this slide talks a bit about what I've already said, whether you call it causes or whether you call it associations. People with obesity are more likely to have fat in the liver, simply put, because you have fat all over the body. You have people who have what's called metabolic syndrome. What is metabolic syndrome? It's people who have a combination of diseases. So they can have diabetes, they can be overweight, they can have high cholesterol, they can have high fats in the blood, they can have high triglycerides, they can have high uric acid. These people tend to have fatty liver. Certain foods cause fatty liver. Of course, alcohol also causes fatty liver, but again, as I said to you before, it goes into a different category. Inactivity or lack of exercise can cause fatty liver simply by causing weight gain. And some people have a genetic predisposition to having fatty liver. So these people are not obese, they are thin, they're healthy, but they still have fatty liver. And that's something we are seeing more and more commonly in lean people. The association between fatty liver and obesity is very strong. It goes hand in hand with the association of diabetes and fatty liver. So simply because you're overweight and you have excess fat in the body, this fat eventually also starts in the liver. And when you start going up to about 5% of the liver being fat, we call this fatty liver, and this can cause the scarring of the liver. Diabetes is the other one. Patients who are diabetic are at increased risk of getting fatty liver, and patients who have fatty liver have increased risk of being diabetic. Now, this is not taking into account the obesity itself. These are people who are thin, can also get fatty liver with diabetes, especially if your sugars are uncontrolled. We use a very simple test called an HbA1c, which measures sugar over the past 3 months. And we like it to be around number 6. When you start getting more than 6, we say this is diabetes. So people who have the higher the HbA1c, going to 7, 8, 9, are more likely to have fatty liver. So diabetes per se can cause fatty liver, but uncontrolled diabetes is more likely to cause more fat in the liver. What are the symptoms of fatty liver? Well, The problem is that there are no symptoms in most cases. So most people who have fatty liver have zero symptoms. They don't even know they have fatty liver. It's an incidental finding, either when the doctor examines him and finds the liver enlarged or when they have a simple ultrasound. Some people can experience a mild discomfort in the right upper part of the abdomen or the tummy area. They may get some sort of fatigue, some tiredness, but generally the majority of patients don't get symptoms until it is too late. And when I say too late, means that the fatty liver has caused inflammation, the inflammation has caused scarring, the scarring causes cirrhosis, and when you get cirrhosis, you tend to get extreme symptoms, symptoms of tummy bloating up with fluid, swelling in the legs, confusion. But the problem is by then you've already reached end stage of the liver, and the treatment is, along with some medication, is eventually liver transplant. So the aim of this talk today is to actually tell people who are at risk of fatty liver that it's now is the time to intervene. Now is the time to go for a diagnosis. Now is the time to go for treatment, consult a doctor, and change the lifestyle to try and reverse the fatty liver if indeed is present. So how do we diagnose it? Well, there are multiple tools which should be diagnosed by the doctor you see, from simple examination to simple scans, blood tests, and then going on to more fancy scans and even biopsies. I'll talk about all of these very briefly. The most common blood test we do for fatty liver is liver function test. We are looking for two parameters, an SGOT and an SGPT. And if these are high, along with an enlarged liver from fat, we say you've probably got fatty liver. And in fact, not only have you got fatty liver, but you probably got a bit of inflammation as well. So a high SGPT or high ALT with a fatty liver on a scan is not only telling us there's fatty liver, it's probably telling us there's a bit of inflammation going on. The problem with this test is that many people who have fatty liver, many people who have inflammation from fatty liver actually have a normal liver function test. And as you can see from this slide, it says up to 80% of patients can actually have a normal liver function test. So an abnormal test is great help, but a normal test does not exclude fatty liver. We have various fancy tests which have come up over the past decade or two, where you take multiple parameters from a person. You take their age, you can take their weight, you can take their height, you can take the body mass index, you can take their blood score, and you put it into a computer-generated calculation, which you can find online. Laboratories are offering it, and it gives you a predictive score of how likely you are to have fatty liver. These tests are useful, but they've never really become very popular simply because they're cumbersome, different scores that is difficult for people to remember what the score actually implies, and various centers use different scores. So it's not something which is commonly used by doctors. We still tend to stick more to scans and simple blood tests and examination, but these can help us. One of the reasons, and another one of the reasons why these are not becoming popular is because of better tests that are coming, and I'll be talking about that. But before we go on to the better tests, the most simple, the most common way of diagnosing fatty livers is an incidental ultrasound, which is being done for routine investigations, is done as part of investigation for abdominal pain or whatever it may be. It incidentally picks up fatty liver. The scary part is that it is so common for us to see it now that people are thinking that if you have fat in the liver, it's more of a normal variation and is trivializing the issue out here. And I repeat that fatty liver on its own today does not cause problems. It's 10, 15, 20 years later, we are trying to prevent irreversible damage of the liver. So ultrasound is great. It's simple, it's cheap, it's easily accessible, it's easy to read. The problem is it only picks up fat when you've got fat in the liver more than 25%. As I said earlier, fatty liver is something more than 5%, 5 to 10%. So a whole host of patients who actually have fatty liver are reported as not having normal fat, a normal ultrasound showing no fat in the liver. And an ultrasound is very user dependent. That basically means that different doctors will report different findings. One doctor may say you've got 10% fat, another doctor may say you've got 20% fat. So these tools where you have fatty liver grade 1, grade 2 are always approximate. And the point I'm trying to make out here is people who have, let's say, grade 2 fatty liver, and they come back 6 months later saying it's grade 1, it doesn't necessarily mean there's an improvement. It may just simply be a variation in the reporting from a different doctor and a different machine. I did say that the fancy scoring blood tests that we used before are not being commonly used now. And one of the reasons for them is because of the new test which we are using called a fibroscan, which is an elastography. If you think of the liver as a sponge, uh, you know, uh, uh, when this liver starts getting scarry or when it starts getting fatty, that sponginess becomes slightly harder. It dries out, if that makes any sense. And fancy ultrasound-like scans can actually pick this up, and we can measure not just the fat, but we can also measure the inflammation that the liver has. This is very, very useful, but it is again not a gold standard, simply meaning that it depends on person to person, it depends on machines, it depends on the scoring system, and it depends on the technician. And if you actually ever go for these, you'll find that the technician or the doctor doing the test will actually measure your values 10 times and take a mean reading. And the reason for that is because we know it's not that accurate, so we tend to take an average. So it's a very useful test to pick up a disease. It's not necessarily a very useful test to give us severity. It is used in that, and there are better ways, but it's because it's getting more and more easily accessible, because it's easy to do, non-invasive, we are tending to use it a bit more. One of the problems is that in obese patients and patients who have had, surgeries on the tummy area and there's scarring around the liver, it can give us false values. So a great test with some limitations. MRIs, very, very good, very accurate in picking up fat content. The problem is it's costly and it's not done by every MRI. You have to have certain protocols to do it. So some of the bigger centers are offering it. So as doctors, we tend to use this very exclusively for certain group of patients who we are not sure exactly how much fat's going on. We are a bit confused as to what the diagnosis is, but we don't tend to use it commonly day to day in patients who come to us in clinic for simple fatty liver or simple ultrasound showing a fatty liver. What's the gold standard? The gold standard is the liver biopsy. It will give you not only a score of the fat, it will also give you the amount of inflammation, and probably the best test we have, but again, very rarely used because of multiple reasons. It's painful. It's an invasive test. It's got a slight complication rate, very rare, but you do have complications of in the order of 1:300 having bleeds. And worst case scenarios, even 1:1,000, you can have something more serious. But it does have a role, I think, in patients who have abnormal liver tests showing fatty liver, and we are not necessarily sure if there's any other disease going on. I think it's probably the gold standard. We would like to exclude certain things and say, listen, your liver is damaged simply because you have fat as compared to something else. I think liver biopsy has a role. How does fatty liver progress? Well, this is a slide which, forget the fancy words, simply put, the first box, MASLD, is fatty liver. Uh, Up to a quarter of these patients will progress to inflammation of the liver, which is the MASH box in the center. So fatty liver does not necessarily mean that you will always get inflammation. Some people will just get simple fat in the liver. It will not progress. They will never have symptoms and they will never have any problems. But a quarter of patients will actually progress to inflammation. This inflammation will cause scarring. This scarring will cause cirrhosis, and this cirrhosis will cause symptoms, serious symptoms, up to 20% of people, 30% of people with cirrhosis over a span of 5 to 7 years will get symptoms. And these are the patients who will eventually require liver transplant if appropriate. One of the concerns of cirrhosis is that it can cause cancer, and this cancer is a very aggressive cancer, which is diagnosed often late, precluding the help of a liver transplant. So patients who are on cirrhosis tend to have every 6 months, we tend to do ultrasounds trying to pick up early scans, early evidence of cancer. What's the management? We tend to use multiple protocols out here and multiple arms. I think the first three are probably the most important. I know one of the reasons we're talking about this today is to try and tell people about the medication available. But I think medication is actually just the tip of the iceberg. I think the diet, the lifestyle changes, the weight loss, the sugar control is more important out here. I think if patients come to us and we give them medication without emphasizing this, they think we're giving this magic drug and they don't need to change their lifestyle. I think it's very, very important you change your lifestyle in terms of diet and exercise. And I'll talk about each of them out here. Weight gain, obesity, weight loss rather. Weight loss is probably one of the most important features in people who are overweight. If you can lose around 5% of your body weight, you will decrease the fat. If you go down to losing about 7 to 10%, you will also decrease the inflammation and sometimes even the scarring in the early phase, which we used to think 20 years ago was irreversible. We are now finding is reversible. So I think people who are overweight, even by a small margin with fatty liver, that that weight loss, I think, is something that they need to aim for. A lot of patients who are on a diet, on an exercise, on a weight loss diet and exercise program come to me and say, we've done this and we've only lost 2 kilos and 3 kilos. My argument is 2 kilos is 2 kilos. You know, if you pick up one bottle of Bisleri, that's 1 kilo. For people who think 2 kilos is little, pick up two bottles of Bisleri, walk around for 20 minutes, your hands will get tired. That's how much is 1 or 2 kilos of weight here and there. I think it's a huge amount of weight loss in a span of a couple of months. Aim for anything between half kilo to 1 kilo per month. You're talking about 6 to 12 kilos over a 12-month plan. The process of weight loss is never a 100-meter race. It's always a slow process. Don't go on crash diets. Always think of a lifestyle change to try and lose weight over a period of time. As I said earlier, if you lose, 3 to 5% of your weight, you will actually reverse the fat in the liver. If you go up to more than 5%, you'll start decreasing the inflammation. If you start reaching 7 to 10%, you will start finding the scarring also reversing and the liver becoming back to normal. What is a diet? Well, typically what we consider the Mediterranean diet. Mediterranean diet is fruit, vegetables, with lots of seafood and dairy products. So this is basically what we are focusing on. One of the problems in our society is a lot of the food nowadays is processed. A lot of the food is cooked is fried in deep oil. A lot of the food is non-vegetarian red meats, which can all predispose to fatty liver. One of the myths about fatty liver is that fat causes fatty liver in the diet. Yes, it does aggravate it, but actually it's a high carbohydrate, high sugar diet, which actually causes, which is the main factor of fatty liver. So a healthy diet overall, see a dietitian. I always say see a dietitian. I know people nowadays Google it, but I still think a dietitian takes into account a more personal approach compared to what Google can do. Everyone's diet is different. People are from different backgrounds, different religions, different, vegetarians, non-vegetarians. So I think it's important to see a dietitian to try and figure out. Exercise, any exercise that makes you sweat. And I think that's what we talk about, aerobic exercises. I know that resistance exercises has a role, but I think that's something which should come later on. I think aerobic exercises that make you feel tired, is a good starting point. And then you can go on muscle building later on. So as I said to you earlier, diet, exercise, weight loss, lifestyle is more important in dealing with it. A holistic, healthy life is what we are aiming for out here. Nevertheless, medication has a role. Historically, doctors have used two different drugs. One is ursodeoxycholic acid. I think, fancy name, big long word, but I think a lot of you would have heard of it as Udiliv, which is commonly one of the brands, very commonly given in India, and vitamin E. The problem is that there's not a lot of evidence for either of them. In fact, Udiliv or ursodeoxycholic acid, in fact, pretty much has no evidence, used across the world, off-label. But if you look at most guidelines, going from the American guidelines to European guidelines to the British guidelines, none of them actually put vitamin E or Udiliv into their protocol of treating fatty liver. In India, it's very, very commonly used, unfortunately, because it's an expensive drug. And I understand 10, 15 years ago when we didn't have alternatives, you give something in the hope it gets better. But today they are better medicines that we have. Pioglitazone and saroglitazar are two drugs that have come up, and there are a lot more in the pipeline. In fact, there's a medicine which has also been approved in the US for fatty liver. In fact, it's the only medicine approved in FDA approved. But there are 2, 3, 4 drugs out here in India. Saroglitazar seems to be probably the leader. I think the data does suggest that pioglitazone and saroglitazar is better. one of the reasons saroglitazar is in the lead in India is because the data is there. Plus, also a lot of research has actually happened in India. So a lot of the studies that have happened, I know studies are going across the world, but a lot of the early studies came up in India, and we started using it in diabetics who had fatty liver, in obese patients who had fatty liver, and we started finding good results. So it moved on from using it in patients who didn't have diabetes with fatty liver. So they just had fatty liver with maybe high cholesterol, or they had fatty liver with obesity. So these various categories have been used, and it's been found that it does reverse and improve fatty liver and the scarring of fatty liver. I don't think the data is very strong in terms of people who have incidental fatty liver, the lean people who are not diabetic, who don't have who are not obese, who don't have high fats in their blood. I'm not sure about that data. I think that's still a bit too early, but it seems to be the drug which is working right now. As I said, there is other medicines that have been approved, resmetirom, which has been approved, which has also been shown to reverse fatty liver. I don't want to go into the mechanics about this, because I think this is more for patient awareness. So what is the summary of this? Healthy lifestyle, eat healthy, avoid alcohol, even though alcohol has a different uh, mechanism of causing fatty liver. It does aggravate it. Exercise, lose weight. If you're diabetic, make sure you try and stick to your diet, your medication, try and get your sugar control well. See a doctor. If he needs medication, investigations, he will put you on medication appropriately. And remember, the way obesity is a lifelong disease, and the way diabetes is a lifelong disease, I think one thing we have learned is that metabolic or fatty liver is also a lifelong disease. So it's not about taking medication or lifestyle changes for 6 months and reversing the fat. It will come back if you're not careful. I think I'll end there, because I think it would be nice to actually take questions rather than anything else. Thank you.
Thank you, sir, for this wonderful talk. This has enlightened us. Now, with your permission, sir, I would like to hear your thoughts on few questions. So, the sir first question is, how common is MASLD and MASH in Indian population?
I think the slide did talk about it. Up to one-third of patients across India have it. I think us working in Delhi, at least we see it in many more, because urban lifestyle is more about fast food, it's more about overeating. So I think we tend to see it in even many more. I would say up to 50% of people in urban India actually have fatty liver. It's literally it's an epidemic. I mean, when we had COVID a few years ago, we had 3%, 2%, 1% of people getting it. Here you have 30, 40, 50% of people with it.
Yes, sir. So, sir, second question is, can NASH and NAFL be age specific?
Age specific? Well, we tend to find that you with age your fatty liver increases, but that's also because your obesity, your weight increases with age. We also find a lot of the younger generation today, even school going, having wrong eating habits and lack of exercise, and you find obesity in schools. So what used to be considered to be a middle-aged disease is now coming up to teenagers and even younger than that. So yes, it is age specific. At the same time, age is not a very big criteria or a parameter that we use for fatty liver.
Yes, sir. And sir, is fatty liver reversible disease?
Oh, categorically. And that's something I think people need to understand. The stages of fatty liver, you have normal liver, then you go into a fat in the liver that is reversible. You can go back to a normal liver. Beyond fatty liver, you get fat with inflammation. That's also reversible. And I think that that's very important to understand, that when you get inflammation, you can also go back to a normal liver. The next stage where you get fibrosis, there is evidence that we can reverse fibrosis. We may not be able to bring the liver back to normal, but we will be able to uh, improve the liver. I would even go one step further and say, when you have a cirrhotic liver, remember, when you have a cirrhotic liver, it's not like the whole organ, the whole liver itself is dead. There are parts of the liver which are dead. There are parts of the liver which are scarred. There are parts of the liver which are inflamed. So our aim in that situation is that the parts that are inflamed, the parts that are scarred, to try and reverse them and bring them normal. Sure, there's some parts we won't be able to get normal, but overall, the liver function, we would like to try and improve, and more importantly, also try and prevent the liver getting any worse. So fatty liver should be treated like as a reversible disease.
Yes, sir. And so, what is the ideal diet recommendation for MASH patients?
So a lot of people put vegetarian as the gold standard in of a healthy life, but that's not necessarily true. I think a balanced diet is important. Everyone needs fats, everyone needs carbohydrates, everyone needs proteins, and certain animal proteins are considered to be slightly more nutritious in some aspect. Certain vitamins that we don't get commonly in vegetarian diets are in non-vegetarian diets. So I think um, a vegetable diet with a fish component or a white meat component, I think is a balanced diet. I think the oil should be a healthy oil. I think we should not be using, fatty trans fats. Um, Dairy products, I think, are good out there. So a balanced diet. I don't think anything in particular should be too much or too little. Yes, of course, we need to avoid red meats and we need to avoid the high sugar diet. And I don't say that as the high carbohydrate diet. I said the high sugar diet, and that comes from sweets and cold drinks and the simple sugars. So I think a balanced diet is important out here.
True, sir. Now, on behalf of NASH 24 by 7, I extend my sincere thanks to Dr. Vivan Talwar sir for his enlightening and engaging talk on MASLD. Sir's insights have highlighted the critical need for increasing awareness about fatty liver disease. And now I also want to express my appreciation to the audience for their participation and valuable contribution. Your feedback and suggestions are essential as we strive to enhance our future Facebook Live programs. So please stay connected with Nash 24 by 7 on Facebook for further updates and information. And take care, stay well. Thank you. Thank you once
Thank,
again.
thank you, Ketki. Thank you, Zaid. Thank you.